So welcome, everyone. In my role of pre-announcer, I have just two announcements. They are both concerning celebrations. We will have our sesquicentennial, or every 5-year, Paella Fest coming up on the 30th up in Tilden Park. That will be on Saturday. Everyone is welcome. Also, children, partners, pets, everyone is welcome. There's bus transportation. There will also be some transportation here. And the second thing to keep on your calendar is graduation, which is the 17th.
May 17th at 2 p.m.
Look
Bring
forward
friends,
to-
family.
Great.
Did you give a time? Probably not yet.
I don't think is there a time for the picnic? I don't know if there's a time.
I think it's at noon.
Noon. Okay.
It's at noon, yeah, at Tilden Park.
And there will be continued announcements about
And
it.
there's going to be amazing amounts of homemade paella. David Rare is making vats of it. And it's a really special treat. If you haven't had David Rare's paella, you must come.
Okay, and I'm delighted that Jenna has agreed to introduce our speaker today. So welcome, Audrey.
Thank you.
It is my enormous pleasure to introduce Audrey Dorélien. Audrey has the kind of creative polymathic mind that defines the very best demographers. She has written on birth seasonality and spatial models and climate change and infectious disease and infant mortality and all kinds of topics that are very rare, that are rarely explored in a rigorous fashion and even more rarely together. My own interest in birth seasonality comes out of anthropology and sort of intersections with biological anthropology, and so to see this done by someone whose degrees are in economics, public affairs, and biology is striking and unusual. Her first degree was a bachelor's in economics and biology from Swarthmore. She then got her PhD in public affairs from Princeton, then was an RWJ fellow at Michigan, and is now at the University of Minnesota, is also in public affairs. She has published in a wide variety of journals, in PLOS, in PDR, in population metrics, among others. And today her talk is taking her out of Africa into the US, continuing some of the same topics, although with a very different kind of data. Her title today is The Effect of In-Utero Exposure to Influenza on Fetal and Infant Outcomes. Please join me in welcoming Audrey Dorélien.
Thank you so much for this really warm welcome. It's my first time in Berkeley, and so far it's been a great visit. And actually, I have to say that Berkeley has produced one of their, I guess someone kind of see as a colleague, but also a role model, Enelio Zageni, who I think is the only other kind of demographer that I've met who's been interested also in some of this infectious disease, I think also climate change, and so we overlap for that. And actually, you'll see at the very last slide some future work with him that I'll be starting this summer and things like that. So I do feel like this is one of the few places where I've seen a lot of my different interests aligned. Okay. So I just kind of want to highlight where this paper topic is coming from and kind of highlight one of my many research strengths. So I've been really interested in kind of the interaction between human population dynamics and infectious disease dynamics, and specifically seasonal infectious disease dynamics. And then likewise, I've been interested in, I guess, kind of the inverse, but how infectious disease might also influence infant and human health. But in terms of infectious disease, once I caught that seasonality bug, I've been kind of focused on infectious diseases that vary seasonally. So this research that I'm going to present today is kind of, I guess, a continuation of this broader research trend. And this should be coming up. The first is in demographic research. It's in press now, where it was kind of the first chapter of my dissertation where I was really using the demographic and health surveys to systematically document birth seasonality in sub-Saharan Africa. So those are seasonal fluctuations in the birth rate. And then I had a paper in +1 where it took information from that demographic parameters, kind of the birth seasonality, to actually, and this one was a theoretical paper, that showed that human birth seasonality could actually influence the dynamics of childhood immunizing diseases such as measles. So that paper actually showed that you could have two countries with the same annual birth rates, and all the parameters are pretty much the same, but if they had different birth seasonalities, so the magnitude and also the timing, you would have differences in the timing of the measles epidemic, but then you could also induce an annual or biannual, like every 2-year peak. And all of that being driven by kind of this seasonal fluctuations in birth. So it's actually been nice because a lot of the infectious disease modelers that work in sub-Saharan Africa have actually now started. I get calls like, what are the parameters looking like? And they're actually starting to incorporate kind of this birth seasonality in their models, and they're finding that the models have better predictive capabilities. And then that also tied to a paper that came out in Biodemography and Social Biology last August, where there I was looking at the effects of birth month on child health and survival in sub-Saharan Africa. And basically, so there I was in the sub-Saharan African setting, but as part of an RWJ postdoc, that actually kind of forced you to diversify and actually do a little bit more US, because RWJ is about improving American lives. So that's where I came up with this project, which I'm towards the tail end and really hoping to submit in the next month or two, so feedback will be very crucial. So here I'm looking at the effects of in-utero exposure to influenza and fetal and infant health. So it kind of stems off from this previous project where I knew there was a relationship between birth month and health, but I wasn't necessarily able to test a specific factor. So here with the US setting, I'm specifically testing the role of seasonal influenza. And what was nice, and I guess working on US data, I'm like, wow, there's so much high quality data. I don't just have birth month, I actually had this gestational age. And so it actually lets me do certain things that I wasn't able to do within the African setting. Okay. So some background on US infant health outcomes. So these were the latest 2014 statistics, where the preterm birth rate, so I'll say PTB, so it's births less than 37 weeks, it's about 10% of all births. And for low birth rate, that's about 8% of all births in the US. And for the US, we actually do very poorly in these infant measures, especially in comparison to OECD countries. And I think some of these rates, they say sometimes the US is comparable to Somalia and some of these other countries. Okay. And why do we care? We really care about kind of these in utero and early life exposures because there's all of this literature that's shown that infant health, in utero health has significant consequences for later life economic, educational, and health outcomes. But so given these poor infant health outcomes, many folks have studied the rising obesity, delayed maternal age, and multiple births because during the period of time that I'm studying, a lot of these health outcomes actually worsened. But now it's actually has improved a bit. And given my interest in seasonality, I just wanted to highlight that a lot of the people who study it focus on maybe the annual rates, but I was very surprised and interesting to learn that a lot of these outcomes of interest actually vary by month of conception. So here these are rates of, this is birth weight. And you actually see that, and this is by month of conception, not month of birth. But you actually do see that even in the US setting, there's actually these variations. So I thought that it would be important to look at seasonally varying factors. I feel like so. And do stop me if you have questions or want clarification. Alright. So in terms of factors that may vary seasonally, people have started looking at the role of pollution, ambient temperature. There's Tim Bruckner that's looked at that, nutrition. But in the US setting, I don't believe disease has been as well studied. And that's where I've been really interested. And I guess I just wanted to say in the background, so we do know, and there is precedent, that infectious disease does impact your in-utero environment. Specifically, historically, rubella has been shown to induce cardiac defects, hearing loss, cataracts, and low birth rate. And what's really interesting with the rubella case is that the timing of the exposure matters. So depending on the trimester of exposure, you don't necessarily get those same outcomes. And then now we're seeing in the news with Zika virus, that's kind of reminding us that infectious disease can actually induce, or that I guess the uterus is not necessarily complete protection. In this case, the Zika virus is actually crossing the placenta. Okay. So when I was talking about seasonally varying factors, kind of like air pollution, infectious disease, those have influence infant health outcomes, basically because of differences. Fetus conceived in different months will therefore experience different prenatal conditions, and you can also see that they'll experience different conditions during infancy. So because both of those have to do with the timing between the exposure or the seasonality of the effect. But I want to take a second or a minute to highlight two other factors that can actually cause this. The first is maternal selection, and that's where a lot of the economists have focused. So you could have, let's say that we have no seasonally varying environmental factors. But in the US, and actually my own research in Sub-Saharan Africa, I found that women of different socioeconomic background actually have different seasonal fertility patterns. So in the US, so even in the US, I think Berkeley and Hungerman have shown that a lot of babies born in kind of January, February, they term them prom babies. So they're more likely to be born of unwed teenage mothers every single year compared to babies born in the summer are more likely to be born of high-income, highly educated mothers. So in that fact is that some of these babies, it might not be the seasonal environment, they may already be different at conception. Okay. And for the Buckles and Hungerman, they actually found that when you look at some of these birth month or conception month outcomes for US, 50% of that is explained by that maternal selection, that they were already different at conception. Okay. The second factor that people, I think is just right now, people are starting to look at, but really hasn't in all of this literature, is confounding due to missing information on gestational age. And that's because most of the folks, all the historical stuff, only had really month of birth. You don't have gestational age. So once again, you could have no seasonally varying environmental factors, but I guess I'll give an example that'll make it clear. If you have seasonality in conception, and we know that happens, what happens is that 9 months after the peak conception month, you're going to have lower rates of preterm birth. That's because after that peak, most of the preterm births would have occurred 8 or 7 months before. So that's a structural thing that if you don't have the gestational age, you'll have some of these outcomes vary by month of conception, and there's no seasonality to it. It's just because of this gestational age. And many of the papers, and even my paper where I was looking at it in Sub-Saharan Africa, I had to, look at the birth seasonality to actually say, well, maybe this birth month that's associated with this positive health outcome, maybe there might be some bias because of this missing gestational, especially if the best birth month coincided with the with the peak seasonality, birth seasonality. So in the US data, I'm able to control for this aspect, but I just want to highlight because I don't think most papers mention any of these. Okay, so now the focus on influenza virus infection. So influenza is a significant source of morbidity and mortality in the US. About 10 to 20% of the population is infected annually, and that results in about 25 to 50 million cases in a typical year and 30,000 to 50,000 deaths in a typical year. And I just want to highlight that during the time that I'm interested in, so late 80s, early 90s, up to 2004, historically there was also very low vaccination rates, especially in the population I'm interested in. I think back here was like 1% or almost none. And it's today, really after the 2009 H1N1 epidemic, that vaccination in pregnant women increased, but it's still not universal. And during the time period I'm interested in, it's still low. And I guess I have to remind folks that with the vaccine, it's not always necessarily effective if there's a mismatch between the strains. So in terms of influenza, there's antigenic variability of the virus, so that's why we actually have emergency. We get new strains every year, which is why we actually get annual epidemics. In the US, it's seasonal, and the influenza tends to peak between November and March. And the key is that influenza virus produces febrile respiratory disease in humans, with symptoms lasting about 1 week. But in some cases, patients do go on to develop influenza viral pneumonia or later develop secondary bacterial pneumonia. And I'm giving some of these details about pneumonia because I'll explain how I measure influenza exposure. So in terms of the mechanism, so pregnant women, they don't have an increased risk of contracting influenza, they have an increased risk of adverse effects once they contract it. And the key is that unlike the Zika virus in this case, influenza virus actually rarely crosses the placenta to infect the fetus. All of the impacts, it's really secondary effects. So it's as a result of inflammation or hyperthermia that accompanies the influenza. So that's what may impair the fetal development during certain stages. So it's not the virus itself crossing the placenta. Yeah.
By hypothermia, you mean having a fever?
Yeah, having the high fevers, yes. And then also you could think that maternal influenza may impact birth weight by affecting nutritional flows. If you're throwing up, you're not eating. And there's some studies that have shown that maybe the effect would be most severe for women with low nutritional stores. So like if they were low BMI and so on. Any questions?
So we have 10% of, maybe 10% of pregnant women getting the flu, and then is it 1% that are having these severe symptoms, or?
Well, so in terms of the symptoms, and this is something that I'll highlight more in the discussion, for the mother, the symptom increases with gestational, with gestation. So if you get influenza in the first, let's say, month of pregnancy, you're probably not going to have that severe. But if you get it in the last few months, then you are more likely to have severe outcomes. But I'll actually show that, and that's one of the reasons where when they did recommend vaccination for pregnant women, they're like, oh, you really want to get vaccinated if you're giving birth around the influenza. Like if you're going to be pregnant during that, the third trimester ends up being around the influenza peak. But what I'm actually going to show is that even though the mother may not be influencing some of these symptoms, that like my results will actually show that the fetus is vulnerable throughout gestation. And I guess also I'll highlight one more thing. So a lot of studies that have tried to look at kind of influenza and kind of these fetal effects, they may be looking at women who are in the later stage of pregnancies that then contract influenza and go to a hospital. But the issue is that then you miss any of the folks that may have gotten it earlier in the trimester, but the mother may not have had the effect, but the fetus may still have been impacted. So, yeah.
Well, just to follow up, I'm not sure Josh is implying it, but one wonders about like spillovers to other people, or whether we're talking about is just the mom who gets sick and the fetus that we're talking about. And you could imagine that there could be the pre-delivery sort of groups that you get together and you learn about stuff and you transmit the disease from one person to another potentially, I guess.
Yeah, so I guess. So you're hinting that right now they're not saying that pregnant women are at higher risk, but you think that maybe it might be higher, they might be at higher risk of transmission or catching it. Yeah, so that could be. Okay. So in terms of the existing evidence on this, so in the US, this paper really helps me out. So it's by Janet Curry and Hannes Schmutt at Princeton, and they basically had a paper called Within Mother Effects, where they basically showed that even after controlling for that maternal selection that I said could be playing a role, seasonal variation in the birth outcomes remained. And here, so this is just mean gestation length, and they index it at January. And the key, and this is the green is controlling. So within mother, they basically looked at mothers with children born at different or conceived at different times. But you see that it lessens, but even after controlling for this within mother effect, you see this pattern. And then when they stratify by different maternal characteristics, you always saw the same pattern. But then what their paper showed that it was really interesting that the month of conception, May, and this is with February birth, peaked with influenza patients at birth months. So there they couldn't test, but they also had the hypothesis that maybe influenza might be playing a role. Okay. And then other studies that have really come from vaccination trials have shown that maternal influenza immunization actually resulted in lower rates of preterm birth and small for gestational age infants. But those results, they found that it only worked during the influenza season, and then the effects were larger during peak local transmission. So there's starting to be more growing body of evidence that, well, here it's like if you are immune or vaccinated against influenza, then you see improved infant health outcomes. Okay. So what do I try to do with this paper? So here I'm really interested in what are the critical periods of periods for influenza exposure. So is it exposure in the first few months of conception, in the second trimester, or the third trimester? And I'm really interested in what is the total effect of influenza exposure throughout 9 months of gestation on the different infant health outcomes. And I'll highlight which outcomes I look at. And then here I won't present so much, but I was really interested to see how much of the seasonal variation in outcomes by conception month might be explained by influenza exposure. So data. Let me see how I'm doing on time. So the data comes from the National Center for Health Statistics Birth Cohort Length Infant Death Dataset. And I have data from 1989 to 2004. And the key is that I have birth month and year, and they also provided information on gestational age. So I used the same formula as Jeanette Curry did to then calculate conception month and year. And all the analysis is always done at conception month or conception date. And then I have hosts of social demographic factors: sex, birth order, plurality, maternal age, education, race, marital status, prenatal care use, tobacco and alcohol use, and the key is that I have state and county of residence. Yes?
So just to understand the data, is this only for conceptions that end in live births?
Yes.
So I guess more broadly, then what's the role of fetal loss in this? It seems like if we think influenza exposure has bad effects, maybe it has terrible effects.
Yeah, so I actually did also download the fetal death. So I guess it's always censoring. And I did, so this is for given that they resulted in live birth. But I think the data is just really bad. Like really, really bad, the fetal. So I do think that and you'll see some, I do think that influenza exposure, maybe especially if it's in the first few weeks, could actually result in miscarriages. Other studies have shown, but I want to, but I think it's just the quality. There's always some kind of censoring, because for instance, even the fetal death database, it's only fetal miscarriages reported after 22, So then what if it happened before? So you always have a kind of a before issue. Yeah, but that's a very good question. And then the outcomes of interest. So here I highlight preterm birth, low birth weight, and infant mortality. But I also look at gestation length and birth weight. In terms of my sample selection, I limited it to singleton births with no missing information on gestation length because I needed to get that conception date. And then residents of counties with more than 250,000 inhabitants. So the reason why I have to do that is that for that data set, that's the only way I get the county FIPS. Otherwise, it's not, it's not identified, and I need the county information to link it to my influenza exposure. So in terms of the summary statistics, so my sample goes from conception year 1988 to 2004. You get preterm birth about 10%, low birth rate 6%, infant death 0.6%. And this looks actually very similar to the table that Janet Perry had and also the overall US population. Okay. So source of my influenza exposure data. So there I use the NCHS multiple cause of death data files. So I use the ICD-9 and ICD-10 code. And I basically coded all instances where influenza or pneumonia are listed as a primary or secondary cause of death. And I also had the monthly number of deaths by county. So I could combine that data with county population size to obtain county level monthly influenza mortality rate per 100,000.
You adjust for age in some way?
So here I don't, but I'll explain, yeah, because I do, so a lot of the influenza deaths are going to be in the population over 65. So actually there is a part where I did have a I did have a variable that's proportion of the county that's over 65, and I do, whether I include it in the model or not doesn't make a big difference, and I'll explain why. Because in my model it looks at within county variation. So then that kind of controls for some of the population, either age structure of the population. But the key is that the monthly influenza mortality was merged with birth data using the conception date variable. And maybe I'm going to see if I, so I guess, let's see. And I guess I want to make sure that like here my influenza exposure, it's proxied by the influenza mortality rate. It's not, so here I'm not using influenza morbidity. So it's actually the morbidity, they didn't start collecting it until the late 1990s. And at first they did it for huge census regions. So, and even then, even the first few years, they just didn't collect anything during the summers. They would only start collecting from November to March. So that data, the ILI, it's more recent, that would be, but it's not necessarily great. And this one allowed me to get more of that historical perspective, especially when we had lower vaccination rates. But then there's some issue, things I had to think about since I'm using mortality. The first is that I thought influenza mortality might lag behind exposure. Like, people are not going to die necessarily right away, and especially if they're elderly, it's that pneumonia. So there might be a 1 month lag. And then another thing is that individuals living in the same county and conceived at the same month year will actually have the same exposure. Because I don't have it at the individual level. I do not know if the mother was, had influenza or not. I know if the mother, a person was conceived in a county, and I know what the mortality rate. So those are some limitations, and that's why any estimates I have will be would underestimate the effects.
I think you're going to talk about it right now.
Oh, okay. So I just wanted people to actually see the interannual variation in flu, pneumonia, mortality rates. So here I just chosen some counties. So this is in Illinois, New Jersey, and Florida. And you see that even within the county, there is actually a lot of variation from year to year. Yeah.
So what are you thinking drives the variation?
So I guess in terms of what drives the variation, and that's why I'll ask another model whether or not I have to control for temperature and humidity. I have seasonal controls that can, because you do see some spatial variation, maybe some behavior, yeah, because there is some, but yeah, I'm not quite sure. But some, yeah.
Does it line up?
Yeah, so this is Florida, so they're all the same height. So Florida is lower than Illinois. Yeah, so I think the way there's a...
What I mean is, is 1980 in Illinois low and...
No, it varies. So I was actually just looking, the color here is not too great, but I was looking, so for Chicago, it actually seems that, so the pink years are the later years, but it doesn't line up exactly. So there's actually a lot of spatial, at least in terms of the mortality, a lot of spatial variation and, yeah.
Have you regressed temperature on the outcomes? Does temperature alone?
Right now I'll show a version of the model where I don't have it, but I've been debating whether or not, I'm like, is this for this paper or a future paper where I also add temperature and humidity. And for the temperature, I think it's cold temperature and humidity. So it's just, so that's something I definitely want to talk about. And I want to see whether or not I do have calendar month dummies that should control for average seasonal factors. So I want to see if I may need more sources.
Are you concerned at all, or could you use the other data set to look at, in building off the variation in flu year to year, it might also be something where virulence is lower, and so people go to work more, it spreads more, and that would kind of be offset from your measure of immunity as a proxy.
So I'll have to look at that. Yeah, because then there's certain different strains, and some years were worse everywhere compared to others. So I'll have to. So virulence. So let me get to the estimation strategy because I think that'll clarify a lot of things. So some of the important features. The first is I have county by calendar month fixed effects. So that means the model estimates relations between anomalous mortality rates and health outcomes for a given county and calendar month. So it's looking at, what county are we in?
Oh, no.
Okay. So in this county, whether or not this January, how the variation, in one January from another January. So that minimizes some of the omitted variable concerns that can vary across county or seasons. So kind of those age structure effects and other seasonal factors. We know temperature and humidity vary seasonally, or other factors. So it controls for part of that. Another thing that I'm adding is linear time trend, and I have different versions of the model where I have a US national time trend, but then I think my final model I'm actually going with a county-specific linear time trend. And finally, I did try to consider using county by year fixed effects. Someone had suggested it, but I don't think that makes sense because that removes all of the source of variation that I do need. So so that one someone had suggested it, but I didn't think it made sense. So this is just showing, and this is because there's actually a break in my data where just the NCHS did not report the information. There was a break in the early 90s. But you can see, so this is the country, you can definitely see that there is this downward trend. So during this period, mean gestation length was actually decreasing. And okay, the colors are really not showing up, and ignore here, so I'm happy Robert is not here because I'm still working on this visualization. So each line is a different county. It's just showing that it's almost everywhere that there's this downward trend. And I've also broken it down by region. Like if I see the colors, then you actually see bands, but it was pretty much everywhere a declining trend. If I look at, now it's actually, I would need a non-linear trend because now it started to rebound. I saw questions.
Talk about maternal age.
So I don't know if it was maternal age. So this one doesn't have any multiple births, but just some factors. But as I said, it started reversing. But there, so this is.
Do you know if the births are C-section?
So I do have that information. So I do think I do have mode of delivery and if it was induced or not. So I think C-section. Because I think there's an issue of whether or not there's increase in induced labor, and whether or not that so I think since then there's been the promotion of decreasing the C-section rate, so I do think that may have contributed to the increase. But right now I do not control for C-section, and it's something I can. This is just proportion preterm, so that one's been a little more steady, but it has been increasing a little bit. This is just the same thing for the proportion preterm. Yeah. It's messy, but it's just to show that overall you do also have these time trends. So in my model, I have my outcome variable. where I is the individual, C is the county, and time, and C is time in month year. M is calendar month, and Y denote year, but that might be from, yeah. So X is the vector of the control variable, so that's why I have sex and all the maternal characteristics. Influenza. So this is where I have a vector of influenza mortality rates during different points in gestation. So I have one, so for every observation, I have their influenza mortality rate at conception, at 2 months of gestation, and so on. And I have it all the way to 10 months because of this lagged effect that I think mortality may lag exposure. Okay, so here I do have a model where I have the proportion of the population over 65. Because most of these deaths are elderly, but actually including this, especially within my within county, doesn't really do much in the model. And then I have county by calendar month fixed effects. And here I do want to say that my final model will have the county specific time trends, but the preliminary results that I'll show you, it has a country, it has time trend. And I guess I'll say the results are, the patterns exactly the same, the magnitude of the coefficient varies. So I'll go a little bit. And then all my standard errors are clustered at the county level. Any questions about that? Okay. So preliminary results. And as I said, this is the results, the coefficients for the model with just a country-wide time trend. So this is for preterm births, and these are so here's the effect of one additional influenza death per 100,000 in the population. And this is the periods of gestation. So for preterm birth, what this is actually telling me is that exposure at almost any time of gestation actually influences it. And there's been some studies that show that early on can induce preterm later on, or here in the last few months may just induce it. Like if the mother has influenza, you could think that it may just induce labor a few weeks earlier. So most gestation months are susceptible to effects of influenza exposure, and over the course of pregnancy, average influenza exposure increases the fraction of preterm birth by 1 percentage points. So the way I did that is that I looked, so this is the effect of one additional influenza death. I actually looked at the influenza mortality rate per month. And this one, yeah, so on average, and depending on the month of conception, the total magnitude may vary a little bit. And this is actually quite large because what that 1 percentage point, when you have a mean proportion of preterm birth in this sample being 10%. For low birth weight, and I just want to highlight that I show low birth weight condition without controlling for gestational age, but then I also show it controlling for gestational age, and that's because someone can be low birth weight because they're preterm versus being low birth weight and just actually being small for gestational age. So here it actually shows me that, so this is controlling for gestational age, that exposure in the last few months of gestation actually increases the proportion that would be low birth weight. In terms of the mechanism, that makes sense because the fetus, in terms of fetal growth, most of it's happening in the last few months of conception. So they're most susceptible to effects of influenza exposure. So over the course of pregnancy, average influenza exposure increases the fraction of low birth weight by 0.68 percentage points. And once again, when you have overall low birth weight rates being at 6.1%.
Average exposure means versus 0?
Yeah, so no one has 0 exposure, yeah. So this is based on the average, so for the US average, I have information on the average influenza mortality rate. So it's almost, see where it's easy. So it's almost taking this coefficient. So let's say we're doing for someone conceived in January, right? It's taking this coefficient and multiplying it by the influenza mortality rate in January, plus this coefficient and multiplying it by the influenza mortality rate in February, and so on. Okay. So for infant mortality, here I actually find that exposure earlier in the first few months of gestation actually has a more detrimental impact, and this makes sense because you can think of it, this is where now the organs, kind of the fetal development is taking place. So over the course of pregnancy, average influenza exposure increases the fraction of infant deaths by 0.25 percentage points, which is significant given that the mean proportion of infant deaths are 0.6%. So the results I showed you were for my model with the, just the US national time trend. So I actually just reran this model with the county-specific time trend. And what I find is that the actual patch shapes, it's exactly the same, but the coefficients are smaller. So then the actual magnitude of the effects are smaller, but the coefficients are all, in the previous cases, the coefficients were all jointly significant from 0. In this case, they're also jointly significant from 0. But I guess in terms of presenting the results of the paper, I need to figure out, do I give a random, I guess the sensitivity analysis, because especially since both of these, as I said, these results are are population average effects, so the actual true effect is probably much larger. And if people want, I have some extra slides that actually just shows the results of the two models.
Does influenza itself have a time trend, or are there certain years that were bad,
So
kind
it's
of random?
Yeah, no, so it's more random. I do think most of so influenza is not the driving factor behind all of these infant outcomes. It's part of it, but it's not the main factors because the influenza time trend does not look like that straight line. But some of the ups and downs, that's where it's making a dent. So in terms of discussion, some of the limitation is that I do assume that the effect of influenza exposure are the same throughout the year. I think that's a reasonable assumption to make. There may be a attenuation because the measurement error in my influenza exposure variable. And then also lower bound effect because it's a population average effect. So it's across all women regardless of actual exposure. And then as you mentioned, maybe I need to add additional controls such as temperature or humidity. So yeah, it's figuring out, should I include that in this paper or not? And it's it's actually a lot harder to get county, like temperature information. Yeah, I can do it, but it's a lot more work. And in terms of discussion, so I guess the main takeaway I want people to take from this is that influenza exposure is associated with important infant health outcomes. And actually depending on the outcomes, all periods of gestation are actually vulnerable. And then I wanted to put the magnitude of this effect in context. So the magnitude of the effect is similar to the population average effect that people found for WIC and the food stamp program in terms of improving infant health outcomes. So it's not insignificant. But of course, in my study, based on the models, I may have a range of the effects, and I do have to realize that whatever effects I find are going to be understated. And then clearly the study does not actually identify the specific biological mechanisms of how influenza is causing some of these infant health outcomes. In terms of policy implications, so we are moving in the right direction. So since the late 1990s, the Advisory Committee on Immunization Practice has actually recommended that pregnant women get vaccinated. The 80s, they're like, no. And actually now I think they've even increased the recommendation that everyone should be vaccinated. So that's improving. And then pregnant women vaccination, I think it's still hovering around 50%. But there's really a push to actually get it more. So I think there's a push of 80% pregnant women vaccinated by 2020. So that's definitely in the right direction. And then also with the Affordable Care Act now requiring health insurance to provide free influenza vaccination, that should definitely improve. But I guess I want to really highlight that that physicians should really highlight the benefit of the vaccination for the unborn child, because oftentimes people focus on vaccination in terms of the adverse effects for the mother, or influenza and the adverse effect for the mother, and a lot of times physicians would really advise vaccination if a woman was giving birth during influenza season. And as I said, vaccination rates for pregnant women have increased from 11% to in 91 to 49% in 2010, but we still need to push for it to be a little higher. And then I actually think that we should really push for more for universal flu vaccine. So these are flu vaccine that instead of targeting they target more of the preserved region of the virus. And that's a lot better because not everyone gets vaccinated every year. And as we said, with the flu vaccine that we have now, not every year it's effective. So this would provide a little bit more protection, but whereas the research is still not quite there. But this is just really pushing for this a little bit more. And I also, so I guess these are my big recommendations. In terms of future work on this topic, I really want to know, and I guess get some of the feedback, like, do I need to add additional controls for temperature and humidity? Or is my calendar month fixed effects, is that enough for now? Should I be doing some subgroup analysis? Maybe looking at smokers, or, and I guess really pushing more, because I do know there's some seasonal there's this geographical variation in influenza. So maybe I need to present the results of what does it look like for Washington State, where I think they have more influenza, you get more influenza versus Florida, let's say. So maybe it sees that out a little bit more. So that's what I have in terms of this analysis. But I did want to show some more future work. So this is with Emilio Zaghini, and once again, it's tying my interest in demography, human population dynamics, and infectious disease. So where I'm moving next this summer, I'm going to try to measure social contact patterns, which are important factors in understanding and modeling the transmission of close contact infectious disease. And actually, a lot of the infectious disease modelers, they make assumptions of who interacts with whom, what age group. We think it's changed over time with changes, population aging, or changes in living arrangements. But actually, all the infectious disease models, they either use data from the UK or just indirectly estimate it, because for the US, they don't actually have social contact patterns. And they can tell you, and I always get emails like, what does it look like for the US? And it's like, we don't know. So we're going to start by using time use survey to measure social contact patterns over time. So at Minnesota, they have ATUS-X, where we have data from 2003 to 2014. So there, not only could we try to get some information about it across time, so how do contact patterns vary in the summer versus winter, we could actually try to get some regional differences. And then based on this, we're hoping to actually go for a grant to actually go ahead and collect it. Because here it's duration of time. We need both frequency of contact and duration of contact. So that kind of gives you a little bit of a preview of where I'm going next.
Thank you, Audrey. We have about 10 minutes for discussion.
Hello, I work with the California Birth Defect Monitoring Program for a long period of time, and it makes me wonder why you didn't look at birth defects, because there's such a greater variation in terms of what the outcome is, what happened during different gestational periods. And also, one of the reasons for starting the birth defect monitoring program was to look at environmental factors. And influenza at the time wasn't really an issue. It was started in the environmental health part of the California Health Department in any case. But it makes me wonder whether there may be environmental exposure differences that occur by month. So that in the summertime or whatever, one is outside more or who knows what. So that might be another factor you might consider.
No, so and other people have studied that. So if people know air pollution impacts health, but actually I guess, interaction between temperature and air pollution, you actually get seasonal factors. So I think also with lead and rainfall, yeah, so there's actually some of these other environmental factors can vary seasonally and can have some of these same types of effects. The thing is that I can't test them all at once, and the key is that I have to assume that I guess my variation in influenza is not going to mirror the patterns for air pollution or some of these other factors. But I do think people should start paying attention. And I know for air pollution, some folks are definitely looking at that. And I think lead also, with the it varies seasonally, the levels.
Well, it would also be exposure to just being outside.
Yeah.
To,
No, because of behavior, exactly.
Yeah, and garbage. I mean, just getting closer to major environmental problem areas and so forth.
Yeah.
I'm curious, because you've estimated the effects and the coefficients are very small, but they're significant because your sample is so...
It's so big.
I'm curious, but then the significance becomes important when you sort of multiply that by the large sort of effect. But I'm curious if you can put confidence intervals on those estimates, given the sort of range of how small these effects are, that you're multiplying a small effect by a large number. And so a little bit of variation in that small effect is likely to produce lots of uncertainty in the output. And so I'm curious sort of what bounds we should put on the implied effect that you're observing, if it's roughly the size of Wick, or it could also be as low as what else and as big as what else.
Yeah, no, so I have not done that, but I think that would be good. It's figuring out how, so I think I may definitely want to do that. And I have to say that the reason why I still have big confidence intervals is because I have 231 counties. So that's why, like otherwise it should have been way smaller. So I feel, so I do think that maybe in my next my revision, I do want to take your suggestion and put bounds on when I present the total effect, actually showing a range. So I will actually do that. Thanks.
So it sounds as if you could, you have data for some years on morbidity, I think. And you probably also have data for those same years on mortality, and so you could get some notion of what your results based on the mortality outcome imply for, not outcome, but measure imply for exposure. And that would be interesting.
Yes,
I think. And then I was thinking you might also be able, this is sort of downstream calculations from your results, you might be able to calculate how big the effect would be of, say, universal immunization, or how that would affect your outcome. You probably have enough information to, it's just a matter of interpreting the outcome.
Yeah.
And then finally, I was wondering if there's been so much focus on the effects of the 1918 influenza pandemic. I wonder if your result sheds any light on that literature.
Yeah, no, so most of the research...
Don't answer all of those, just...
No, this has actually been really good. So I'll start with the first one, relationship between morbidity and mortality. So I did start doing that, and I'll show... so I think I had to aggregate my data at these HSS, or at these regions to compare, but I will do that. And I think what's a little hard is that the time period. When I do this, it's the later part of the analysis, but then it might be, I do think I should do that to just see how much of a lag are they peaking at the same time. So that I will do. I like the idea about the downstream calculations. And then the third question was...
Well, any insights for the 1918?
Flu. So yes, a lot of folks had used the big 1918 epidemic, and as I said, that was historical. You had no information on the gestational age, and also usually those were where you, so I guess a lot of it was were you in utero during it or not. So I guess a lot of that literature kind of missed kind of the periods, it kind of were you exposed or not. It did not have kind of some of the finesse in terms of the periods of gestation. So I do add to this, but and also, I guess the influenza, that's a huge shock. So, and I guess it aligns. So here, these are not necessarily the big pandemic, but it's just showing that these smaller seasonal influenza, these smaller epidemics that are more likely to be exposed to one of these than a big pandemic. So I think they're both important. It's just that the pandemic one are the very extreme, while this is actually what most folks are going to be exposed to.
So I guess I wondered about this assumption that everyone has an equal probability of infection, which is sort of data constrained, but I wonder if there's anything you can do to sort of push on that a little bit. I don't know what's in these data, but if there's something like maternal occupation, maybe that would give you some insight into the likelihood of infection. So if people work in schools or hospitals or other occupations identified in places where they might be more infected, I wonder if you find interesting variation there. Or I don't quite know about disease dynamics, but maybe in more dense places infection is more likely, so could you use study density
So
as
so those are great. So the first thing, and this is why I also didn't mind, so I'm already at bigger counties, because it's counties with population over 250,000. So I don't have the smaller counties where maybe they may never be seeded with an epidemic. So there's that aspect. But I'll have to look to see there might be some information on maternal employment, because it could be neat to do I have so much data to see what happens if I look at teachers or something folks that may be at higher risk, to see if the magnitude of the effect, because then they're more likely to get it. They're also more likely to be vaccinated. Well, vaccinated, as I said, during that time it was still low, and actually, and things like that. But I think that's a need, but I have to see. Off the top of my head, I don't know if that data is there.
So if you look at the early years when the vaccination rate is fairly low, do you find differences in the relationship by maternal characteristics like race or age?
Okay. So this is kind of another way to look at it, because there are differential vaccination by characteristics. So maybe looking at it that way. But I haven't done subgroup analysis because I guess I assume that I control for race, but I assume that the effect of influenza exposure is the same regardless of the race.
So I found the effect sizes that you were describing very large. 10% of the existing level, is that right?
Yeah.
So if it was 6%, it was plus or minus 0.6. And so I guess that was my reaction, that they were very large effects. And the idea that there's some other driver of the level of influenza struck me as very plausible. So I think that you're saying this is a minimum, it's a lower bound, but I think it's also an upper bound. Say if it's something like temperature, and if staying inside when it's cold outside and breathing a lot of pumped around air is being hot or whatever is bad for the fetus, if that's part of the effect you're going to get. So that's why I would want to see the controls. And the other part of this is, why would these effects be so large? So I guess the explanation would be that influenza is a relatively modern disease. Dense settlement, we didn't evolve to adapt to fever. But maybe the reason is that these are adaptive responses, and that actually the health outcome, the mother and the fetus are together deciding what to do, how much nutrition to give. So it could be that the effects of being a low birth weight baby when your mom had a fever are actually not that bad, because this is the decision that your body made. So the effects of, as a future project, I guess maybe you could do with 1918, but are the effect of being low birth weight the same for babies who get low birth weight because their mom had a fever versus for some other reason?
So no, that's really interesting. So my effects get a lot smaller once I have the county specific time trend. So I'll present, so the pattern looks exactly the same, but the effects. So so they do get a lot smaller. And I guess in terms of it being very large, I'm going to compare it a little bit more, because there's some folks, as Ryan Brown, I think, who's looked at violence. I think in terms of the magnitude, there's folks that looked at the effects of stress. So I guess I'm going to see take a better look of how my estimates compare to what the effect they've seen for other types of shock.
But your effect implies that because the national rate of
Yeah.
influenza doubles or triples in some years.
Yeah,
And so it implies that we would see the aggregate
yeah,
low-term birth weight go up by a couple of % in those years.
yeah.
They seem like very,
Okay, so.
Does the preterm rate vary that much?
No, it varies a little bit. So the preterm, I just had seen the data for the past few years. So for preterm birth, it had been overall steadily going down. Then I think this year it's unchanged from last year. But then it hasn't varied as, but as I said, those are annual, so I would have to see how much, yeah, I guess that's when I have to go actually see the seasonal variation. But it does, let me actually go back. So here, this is like, so here the overall rate in my data set hasn't varied too much, has stayed around 10%, but you do get these ups and downs. Yeah, I should put maybe more. So yeah, so I do have to, yeah.
so maybe there may be some variation in the flu that you may be able to take advantage of here. There are national high years,
Yeah,
and then there are years where only some counties are
Exactly.
nationally high, and there may be,
yeah. Okay, so that's
We
useful.
must calculate what the implied variations in the total aggregate outcome would be based on the variations in national flu mortality or something like that. That would seem like something you could do and just look at.
That'd be very
value or something,
Yeah.
yeah.
That'd be very helpful.
Okay, these are all very useful. Okay. Any other?
Are we up to time?
one,
Well, I think I'm with Josh, like, I mean, they're large and significant effects for all periods, and you kind of wonder, well, why would they be so large? And so I probably did a very bad job of explaining this, but are there these externality effects? So you've got a reduced form where there's flu mortality, right, that's affecting the birth outcome. And, I mean, so who's dying of the flu? Well, it's not the moms. There could be birth later. It's, we're not measuring their actual flu, having the flu or not, but it could be their grandparents or parents who are dying of the flu, and then there's the stress thing that you're talking about. It could be the older siblings of the children who are being born who are dying of the flu, right? It could be the youngsters too. There are a lot of questions about the mechanisms here that are very interesting, and I think that what you ended with let's look at time use and what happens to households and families when flu hits and heaven forbid kills especially the elderly folks. What happens to the time use? And who cares for them? It's probably moms, right?
Yeah, big double, yeah, that is, yeah. Okay.
thanks for a great seminar.
All right, thank you.